TopMedTalk. Well, hello and welcome to TopMedTalk Down Under. I'm Andy Cumpstey and I'm here again with my co-host Kate Leslie at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine's annual scientific meeting here in Brisbane, in Australia. And again, this is the biggest annual anaesthesia conference in this region. We're expecting over 2,000 delegates to be here joining us this weekend. And we're at our pretty busy booth in the huge auditorium with all the other industrial sponsors right next to a very long and growing coffee queue. And I have to say, Brisbane's been a pretty fantastic place to come and visit, Kate. I've never been before, but it's amazing.
Yeah, it's become a lot bigger in recent years, and I think it's going to have a major sporting event in a few years' time, which is very exciting.
Rumour has it, yeah.
Yes.
I've been doing a lot of getting around the city the last couple of days, and everyone is talking about the Olympics. So that's the event to watch in 2032, isn't it?
Golly, that's a long time away, isn't it?
Well, they don't think so. There's lots of building work going on at the moment, and they're trying to get the city ready. It's going to be a big event, I think, for them. So.
Anyway, listeners, come to the Olympic Games in Brisbane.
Absolutely.
But what have we got coming up now?
Wow, I think we've got some more fantastic guests, haven't we?
We have. Yes, we've got some great interviews just coming up right now, but we've also got some other talks, and you can find links to all of them in our daily conference newsletter via the TopMedTalk app, on our YouTube channel and through X and Facebook. So join the conversation. But on the couch opposite us, we've got two fantastic speakers from the conference. And Eugenie, let's kick off with you. Can you tell us a little bit about yourself and what you're speaking about at the conference?
I'm an anaesthetist based in Melbourne. I work in public and private, work at the Alfred in Austin. Also fortunate to be the Enterprise Professor in Sustainable Healthcare at the Melbourne Medical School. It's a position I've had for about a year and a half in David Story's department with that as well. And I was very honoured to be asked to give a plenary at this conference on sustainability and the perioperative practitioner, really trying to get the message across that sustainability is an area that all doctors, all health professionals have agency in, that we need to take action now, and that there's a real connection between sustainable healthcare and quality healthcare.
Terrific. And Forbes, tell us about yourself.
I actually grew up in northern New South Wales, so not far away from here, near Lismore, and lived on a farm for 13 years, had a platypus in the creek. Yeah, it was an idyllic time. I'm an anaesthetist and intensive care physician in Western Health, Melbourne, and also Associate Dean at Sustainable Healthcare at the University of Melbourne.
Terrific. And you're actually quite famous peripherally to what we're going to talk about for being a co-inventor of a hood for COVID patients. Why don't you give that a plug while you...
Yeah, so that was a fascinating time, diversion caused by a certain pandemic in the beginning of 2020, and working with engineers at the University of Melbourne, Jason Monty, the lead mechanical engineer, developed a personal ventilation hood called the McMonty.
And you're the Mick.
I'm just the Mick, and he's the Monty. It was a great diversion. It was just wonderful to be working with clinicians, infectious diseases, virologists, people who are normally, CSIRO scientists who are normally on the Southern Ocean came and joined us, aerosol research. It was wonderful. It was a wonderful time, despite at the same time treating people in intensive care with COVID-19.
Well, we have your hood in use in our recovery room, and we use it for our respiratory patients. And I think it's been great for the patients, but also for the healthcare workers looking after them.
Yeah, particularly the nurses, yeah.
Yeah. What impact did the pandemic have on your goals for carbon neutral healthcare, Eugenie?
It probably waxed and waned. At the beginning of the pandemic and during that time, there was obviously an incredible increase in use of single-use devices and also disposable equipment, masks, you name it. But at the same time, it brought the health profession together globally and in Australia. I think they found their voice. They got used to speaking up and speaking out around healthcare and public health, which in the past they may have been a bit reticent about, and they got used to collaborating. And going forward, there's been, I guess, also appreciation that our supply chains are vulnerable, always relying on single-use devices rather than sort of that circular economy also threatens how we deliver healthcare. So I think ultimately it's sort of changed the perspective and will help us advance our goals for net zero healthcare.
I was thinking while you were talking about the things that immediately deliver carbon into the atmosphere and things that where it might be a bit delayed. And I guess all of that waste is something that has to be disposed of later on. Does the way in which you dispose of it affect its carbon footprint?
Well, interestingly, the actual waste and its carbon footprint is actually quite a small amount of healthcare's carbon footprint. If you're actually talking about the waste disposing of it, it's more about the actual products to start with. So that whole sort of hierarchy of R's when it comes to waste hierarchy, so actually reducing what you use, reusing first, they're actually the most important aspects. So actually decreasing our waste amounts rather than, of course, recycling is a good thing, and circular economies and systems are excellent, but we need to minimise those waste streams to begin with.
So I think, first thing, Eugenie, fantastic session this morning. It was a really, really inspiring talk, but also quite a scary talk. I think you started off saying this is the first time sustainability has been in the opening plenary, which, I mean, that in itself is amazing to me, but we're in an era now where you can't not talk about the pandemic. You almost can't not talk about sustainability. How have we got to this point where it's not been in the plenary before? I mean, what suddenly changed that's brought it there now?
Well, I think you're probably asking the wrong person, because I've been thinking it should have been in the plenary for the last 10 years. But again, unfortunately, I think it's human nature. Until we actually see and feel change, we are reticent to change. Yeah. And over the last few years, before the pandemic, particularly in Australia when we had our Black Summer of 1920 with the horrendous bushfires, well, over the Australian summer of 2019-20, we had horrendous bushfires across the eastern coast of Australia. Right. Hundreds were impacted by the smoke, thousands upon thousands of extra admissions to our hospitals for smoke inhalation. It was a real wake-up call, I think, that climate change is here. It's happening. Yes, we have known about it for several decades, but it really is impacting our health and our well-being. And I think without the pandemic having maybe come along straight afterwards, it really would have been a call to action, and we would have seen a lot more movement within the healthcare profession and governments all around.
And you gave us almost a never-ending list of pretty scary numbers in that talk today.
Well, I was trying to be positive, actually.
But with a positive outlook at the end of there's things we can do.
Yes.
So that's what I was about to ask you about. I think, at one point you mentioned, I think it was 30 or 40% of healthcare's not as efficient as it could be or not as effective as it could be. But then you gave us some really nice solutions and options of where we can intervene on that. Maybe we can bring Forbes back out at this point as well. But what can we do as individual anaesthetists and physicians to kind of improve that statistic and improve our sustainability then?
It's a sort of a ratio that's accepted in Australia and internationally, that 60-30-10 ratio with healthcare, that probably 60% of our care is really evidence-based or based on consensus guidelines. 30% is quite likely to be low value or wasteful, and 10% potentially harmful. So yes, the take on sustainable healthcare that I was trying to get across was that 30% really is ripe to be addressed. Yeah. And it is about improving our effective path and evidence-based pathways, and what we're doing within our practice, decreasing our unnecessary investigations is a start. Yeah. And I presented some of the work that's been done at the Royal Melbourne Hospital to motivate clinical staff and non-clinical staff to improve their processes. And obviously Forbes has been doing an awful lot over the last decade, moving away from single-use to reusable items, which also decreases our waste.
Maybe give us some examples of some of the things you've done with that, Forbes.
Yeah, I think probably a good one to stand out would be during COVID-19, Western Health went through 1 million disposable gowns.
Wow.
And so similar numbers were happening around the country. Yeah. They're all now reusable. And so just working with infection prevention, the environmental services and the suppliers to change that process was a really positive outcome, with a lot of people engaged in that. And that's I like to think of micro, meso and macro approaches. So that's probably a meso sort of level, because it requires a teamwork, often of people from different departments within the hospital and beyond work together. There's micro levels that also, I think, where you can individually as an anaesthetist change what you're doing. And so, the choice of gas that you use, or how much of syringes and whatever equipment that you're using can all be reduced safely and whilst providing excellent patient care. I think all those little things do actually add up, because we are talking about millions of operations in Australia and New Zealand to start with, and on beyond from that. And then there's a macro level that anaesthetists can also be involved in, as Eugenie was saying in a talk, for example, be involved with changing the hospital accreditation standards and things like that. So it's more of a macro level, as well as influencing government policy, for example. So there's examples at each and every level where you can make interesting and exciting changes. They all require work.
It's the Australian Medical Council, which is the accreditation body for medicine in Australia, recently introduced standards with respect to educating and training medical students about climate change, and you mentioned that in your talk. And those types of learning outcomes are also going to be introduced into the specialist training program standards. So our college and faculty, the next time they're accredited, will be probably accredited against some substantial standards about those issues. And I think that's the kind of macro level thing that you're talking about. I wondered if that was happening at all in other jurisdictions, in other countries. It probably is, Andy.
Yeah, so we've definitely got, there's been a big drive from the Royal College of Anaesthetists in the UK and the Association of Anaesthetists as well to, again, look at reusable gowns. That's been a big focus recently. We've got a similar drive to reduce our desflurane use. And again, you mentioned that in your talk about a set date where it won't be available anymore. We're moving very closer towards that in the UK and looking at nitrous as well. But I think it's also worth picking up on the micro level work that you mentioned, Forbes. And, there's probably listeners we've got at home listening to this who are thinking either, well, my organisation is doing a lot about this, there's not much I can personally change. Or maybe they're sitting there thinking, well, I can do these things, but I'm doing it on my own. I mean, what would you say to those sort of viewpoints? It would be.
So I think that what I would say is that's probably not correct in that there's an overlap between a micro and meso thing. So, for example, like using drug trays that could be reusable instead of disposable isn't really just a micro level effect, because it actually requires the central sterile supply department to be involved, different procurement arrangements, for example, whether you use reusable laryngoscope blades or disposable. You might want to do that as a micro level, but you may not be able to unless you engage infection prevention, the nursing staff, etc.
Yeah,
so I think there's a lot of things that overlap in that grey zone of the micro meso world, and working together as a team is all the difference. And so I would say, no, I think there's an enormous amount that could happen at that level, which is really probably more than just the micro level about desflurane versus SIVO, for example.
Forbes, one of the things that's happened is that the trainees are really worked up about this issue. We've got a great trainee network. I think it's called TRASH. And I remember last year they had a great incentive program to stop using what in Australia we call blueies, which are a plastic thing with an absorbent top on them. And instead of that, at the end of our cases now, we're presented with a variety of different things to put the old endotracheal tube or laryngeal mask on. Could be a surgical towel, a bit of plastic from the head of the bear hugger blanket, you name it. So tell us more about the trainee initiative.
Well, I think Sophia Grobler and Jess Davies really started TRASH too. Fantastic group of trainees. And also there's GASP in the UK that is a similar group doing lots of good work. And so I take my hat off to them, all the good work they've done in that field, both in reducing bluey use, for example, and many other equipment and procurement. Ditching desflurane, for example, is another where really it's been started by them, and the huge changes have been affected at their level. So, for example, Western Health, we're now moved into the intensive care unit and doing similar things based on what they've done there, and reducing the use of unnecessary pads and using reusable pads. One of the really interesting ones, just as a little aside, is recently at Sunshine Intensive Care is, I couldn't quite work it out because we went from disposable to reusable pads, but we're using much less reusable pads than the disposable for. I said, well, that wasn't actually the aim. Infection prevention might get a bit worried about this. And they said, no, it was just that we weren't using 3 of them. We're just using 1 of them because you only had to use 1 of them. And so it was just that thought process. It's fascinating, isn't it, that you've had the behaviour change itself has led to a reduction and a reuse instead of a disposable. So it's actually a double win, which I wasn't expecting at all. So another thing we've got to write up, but just really interesting.
So speaking of writing up, what are your next projects, both of you? Eugenie, you go first.
Something at the moment that we're doing that's very exciting is actually a group of anaesthetists, predominantly from Melbourne University, but are across the nation, are working with the national government and the federal unit and our new Australian Centre for Disease Control to develop some guidelines to detect and minimise nitrous leaks within hospitals. They had promised me that that would be published by this conference, but I think we can just say government wasn't quite sticking to the time there, so it's not out publicly yet. But over and over again, both in the UK and in Australia, we're following what the UK's lead here. Probably 80 to 90% of the nitrous oxide that we purchase is leaked. It doesn't actually end up in any clinical care for patients, and nitrous oxide is a long-living, potent greenhouse gas. So we're really working to address those leaks.
And they come from aged pipeline supplies?
Interestingly, predominantly, but even some relatively new hospitals have, when they've gone looking for the leaks, have actually found significant leaks. And because nitrous oxide is odourless and colourless and not very expensive, it's quite, you can see we get into this situation where it just keeps getting getting put on the manifolds, and no one's really paying attention or noticing where or how it is leaking. And hospitals are beginning to decommission. In the UK they are, and Prince Charles Hospital in Brisbane, so one of Australia's largest cardiothoracic hospitals, decommissioned their nitrous infrastructure in January this year.
It's fascinating. There's a systematic review coming up in the British Journal of Anaesthesia where they looked at the safety of nitrous oxide, and what they concluded was that nitrous oxide is safe, that it's a mild analgesic and moderately useful in various clinical situations, in most particularly in obstetrics and paediatric anaesthesia. And so one could choose to use it on that basis, but that it must always be in the context of its environmental effects. And then Philip Payton has written an editorial pointing out that the data that we have about the leakage of nitrous oxide is not comprehensive enough, and that using cylinders may not be the solution, or perhaps using low flow techniques. So that may really not be the solution either. So would your solution be to just remove nitrous oxide?
Well, they're very good points that you bring up. And obviously, we're talking about nitrous oxide piped infrastructure here and manifolds, and predominantly in non-obstetric hospitals. And so there is a place for nitrous oxide, and we're not talking about banning it. Cylinders are being, infrastructure is being placed with cylinders, and then that brings up issues. It brings up workplace and health and safety issues of moving the cylinders. But, in England and elsewhere, they're managing to do that, and also the venting of the cylinders. So when they get returned to the supplier, and that is actually one of the aims of our new climate and health strategy, is to actually address the venting of nitrous oxide when it is returned to the suppliers, and ensuring that doesn't get vented into the atmosphere.
I had never thought of that before, Eugenie.
It's interesting that you mentioned the UK's been doing this as well. There's been a big drive nationally for us on nitrous oxide, and again, it's one of the priorities of our college at the moment to work on that. And I think in some of the meetings I've been in, often what's proposed as a reason not to do that is the cost of changing some of these systems. And I think often people bring cost in as a negative side effect of trying to be more sustainable, but that's not always the case, is it? I mean,
well, it's not always the case, and I guess it's an individual facility situation. I know at Prince Charles Hospital here in Brisbane, they are thinking less than 2 years between return on investment from decommissioning.
Which is no time at all, really.
No time at all, and that's including the purchase of the cylinders that they will be purchasing to still be able to supply the nitrous oxide when need be.
And I think when we come back to the trainees working on projects, I think with a bit of support, those trainees can very quickly scale up small projects to have actually quite big cost savings. So there's some examples that we've been working on recently in Southampton where looking at just disposable theatre hats. And by, I think, buying 2 to 3 cloth hats for each member of staff in theatres, we think the business case is going to save the hospital £200,000 to £300,000 over the next 2 years.
With your names on it.
Yeah, exactly. And the benefits of all the human factors where that brings in, and it's more sustainable, and it's a cost saving. So I think there's often lots of factors to this, aren't there? They all kind of slot together that what's the right thing to do for one patient may also be the right thing to do for a hospital and for the environment at the same time, if we get it right.
Absolutely. And almost that triple bottom line lens.
Absolutely.
With sustainability being the overarching factor there. And as I mentioned in my talk today, it is a bit of a misconception, I think, that sustainability actions are always a cost. And they're over and over again, and Forbes' research has shown that as well. Evidence, reusable equipment in the long term is cheaper, cost saving compared to single-use equipment.
Yeah.
So Forbes, tell us about what's coming up for you in your research.
Yeah, a few things. I think they're exploring a lot of technical things, but also those other policy and changing behaviours of people is really important as well. So I think that they're dividing into those sort of groups. So I think that there's the work, for example, of Jess Davies that she's doing about translation and how to engage with implementation scientists to change behaviour. I think is really important now for sustainability to get on board. I've always been really interested in engineering, and I suppose some of the things we're doing is a reusable N95 mask.
Can you tell us a bit more about that? That sounds amazing.
Long beta prototype. So it's just using it's basically having there are plenty of, I suppose you'd say, industrial environments, reusable N95 masks that you'll see being worn in construction sites. We were trying to adapt one that actually, that has been improved auditorily, so you're able to speak. Because one of the problems with masks is, of course, you have to yell. And we noted that and so we've got one of our biomedical engineers helping us to project your voice better than what would otherwise be the case with a mask. So I think that's one of the really interesting technical parts that we're working on. Another one is extending the use of a gown. So actually allowing the gown to impregnating a gown with a material that prolongs its lifespan and is antibacterial, for example. Another one would be is the use of reusable wraps. You know, the blue wraps that we use and we throw away in theatres for all the sterile equipment, the surgical and the surgical wraps. So using a reusable variant of that. So yeah, a lot of interesting things with the Innovation Acceleration Program that's developed between University of Melbourne and hospitals. Thanks.
Fantastic. Well, we've only got a couple more minutes to go. And I wondered if each of you could just tell us one thing we can do at home that would make a really big difference to climate change.
Well, having just read the book, It's Not the End of the World, it is eat less red meat.
Right? Noted. And what about you, Paul?
I was going to say the same thing, and I think that's a really important one. But sorry, Kate, I think the other one is don't fly so much. It's not in the home. Maybe fly internationally every second year, so then you've halved the footprint.
Thank you, Forbes. I think I might take the first suggestion and not the second one.
Excellent.
Well, thanks so much. That was such an entertaining and enlightening chat with you, but also your talk was really fantastic, Eugenie, and we're looking forward to your talk tomorrow. You'll be able to find a link to this episode in the daily conference newsletter, on the TopMedTalk app, on our YouTube channel, and on X and Facebook accounts. So thanks for joining the conversation, and see you next time.
Thank you very much for having us.
Yes.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.